So our first speaker is Professor Ken Butcher. So Ken has a very long bio. He's a neurologist. He's a director of Academic Conferrals for the Faculty of Medicine and Health at the University of New South Wales, and he's the medical director of the New South Wales Telestroke Service. He has worked in the field of stroke research and clinical practice for over 20 years, most of which was in his native Canada, and we're very lucky he's come over to Australia now to work with us. So Ken is going to talk to us about the New South Wales Telestroke Service, which was an initiative of the New South Wales Health and operates throughout New South Wales and provides neurology service to those who don't necessarily have neurologists. So welcome, Ken.
Right here?
Yeah, I'm assuming so.
See if we've got something. Yeah.
You'll be able to see it down on the screen down there.
Oh, right. Yeah, perfect. Yeah, thanks, Kylie. Thank you for the kind invitation to come out to Parramatta. You can't hear me over that? Over the coffee machine over there? Squeaking away, it's louder than me. Thank you, Kylie, for that kind invitation. There are two reasons I come to Parramatta, and you alluded to one of them. One is this conference. This is the second time. And the other one is many of you may not know this, but the Citizenship Testing Centre is just down the road, and I was here last year for that. So I'm now a native Australian too, as well as a native Canadian. So let's see, what are we going to talk about today? We're going to talk about Telestroke Service, which I was asked to talk to you about, and the current status, what we're at, which I updated you on last time I was here in 2022. And then we're going to talk to you about some new innovations, and I'm going to try to set up Professor Anderson's talk because we have a shared interest in another type of stroke, which we don't talk about a lot. This slide probably doesn't need to be here for this audience, but it's sort of a motherhood slide. I think you all know that stroke is a very common problem. It's a major health problem around the world and in Australia. So every 19 minutes somebody's having a stroke in Australia. And about a third of those people are going to die, not right away, as many of you know, but within the next year, often from complications of immobility. And the other survivors, as you well know, will require some support, but treatment is possible, and that's just a reminder that stroke can affect anyone at any age, which we heard here on the panel this morning. I always wonder about what level of the audience I'm dealing with, and I suspect most of you don't need this slide, but some of you may be newer to the stroke field, and I'd just like to bring everyone up to speed so we're all on the same page. When we talk about stroke, that's a very general term. It's a really old term that originated actually over 1,000 years ago, and it was based on what people saw on the outside. They saw somebody who was walking one moment and then all of a sudden wasn't walking and had basically what used to be called apoplexy. Now that we can look inside the brain and we can understand the disease more, we actually know it's more than one thing. Most of you, what we've really been talking about this morning are focused on ischemic stroke, which occurs when an artery in the brain is blocked, usually by a blood clot, and that's our treatment target. That's what we're trying to treat in stroke, either with the drugs, which we'll talk about, or the clot retrieval. But the other type of stroke is hemorrhagic stroke, and that refers to most often bleeding inside the brain. To us, looking at the outside, patient looks the same. They just can't move on one side, maybe can't talk, can't really distinguish these two stroke subtypes just by looking at a patient. We'll talk about that in a minute. And that's hemorrhagic stroke. The other type of hemorrhagic stroke is when somebody has a ruptured intracranial aneurysm. That's an aneurysmal subarachnoid hemorrhage. So what makes modern medicine, stroke medicine possible, what makes my career possible, and what makes stroke treatable is this remarkable invention right here, the CT scanner, which we just take for granted today, but this was invented in my lifetime. So in fact, I think it's safe to say, everyone in this room, when you were born, this did not exist. And you couldn't actually reliably even tell those two stroke types apart without it, and you still can't. There are doctors who think they can, but they can't. And I always tell the doctors, if you want to guess, guess ischemia, because that's the most common stroke subtype, as most of you know. Most of the people in the room, either have had or somebody who's had that type of stroke. It's about 85% of the population overall. And hemorrhagic stroke, I call it the Rodney Dangerfield of stroke. It can't get no respect. Doesn't have the same treatment pathways, and because it's less common, it often gets neglected. But we're actually going to talk a lot about it today, myself a little bit towards the end, and also Professor Anderson. In 2024, we now have advanced CT imaging, so that not only can we image the brain and tell you what type of stroke you've got, we can also image the blood vessels. Let me see, what have I got here? I got a laser pointer? I don't know what I don't have a way to point, which is a problem when you're looking at images. No, that's not working. That's just going forward and backward. I guess I'll just describe. The one in the middle, we've given that so-called dye injection. It's not really a dye, but for those of you who have had it, it was that injection that made you feel very warm and flushed and maybe like you just weed yourself. That was contrast going through your veins and then your arteries, and that allows us to look at your arteries. And what I'm showing in the middle there is a patient with a blockage of their middle cerebral artery on the right. Then we use another injection to actually look at the flow in the brain itself. And that's what we call a CT perfusion scan. And really that is what makes the treatments of today possible. It allows us to select the best patients who are going to respond to the reperfusion therapies. See, I had arrows, I didn't have to point. Just needed to use those. And the reperfusion therapies, of course, I think you know about them. We have two tools in the toolbox, which might not sound like a lot, but when I was in med school, there were 0 tools in the toolbox. One of them is the clot-busting drug, which you may hear of referred to as TPA, which stands for tissue plasminogen activator, or Alteplase, which is the generic name for the drug. But it's basically what you have in your bodies that breaks down blood clots when you form a blood clot. And then the other thing we have is what we refer to in Australia as endovascular clot retrieval. Anywhere else in the world, they call this endovascular thrombectomy. And essentially, that's when an interventionalist, either a radiologist or a neurologist or even a neurosurgeon with interventional training, puts a catheter up into the artery in the brain where the clot is and removes it, either by trapping it in a stent like I'm showing you here, or sometimes with a little bit of suction, what we call aspiration, to pull that clot out. And that works really well for big clots. So these treatments, as you know, you've heard, they weren't always with us. Alteplase was first proven to be useful in 1995, but it took a long time to convince the clinical community that was a good thing to do to bring people on board. Then endovascular thrombectomy, that began to evolve really almost at the same time, but it took a long time to actually get it to work. The devices had to be improved. But about 2015 is kind of where all the evidence came out all of a sudden, and it really was, a game changer. I know that that's often overused. But what that meant was stroke became very, very treatable if you were close to centers that offered that. And around the world, not just in Australia, that really meant being in a metropolitan center, being in usually close to a university center, teaching hospital. And if you lived in regional areas, rural areas, remote areas, your outcomes were much worse because you didn't have access to those treatments. And New South Wales was no different. We knew the outcomes were much, much worse from our previous audits, and that's what the New South Wales Telestroke Service was designed to address. It was basically, the concept was, let's try to bring the treatments that we have now in Sydney and around John Hunter, Newcastle, to the regional sites, and those are the 23 sites that we chose. Chosen based on a number of factors: population, interest at the local level, and most importantly, did they have a CT scanner? Because you cannot treat CT without a CT scanner. The way telestroke services work in most places around the world, telestroke's not, we didn't invent it, it's been around for a long time, and in fact, I was part of a service that we started in Alberta, in Canada, and the traditional model, or conventional model, is sort of what I've shown here, is you get a whole bunch of stroke specialists, you pack them into one hospital, you have everybody call one number at that hospital, and those consultants take a roster to cover that 24/7. That will never work in New South Wales because there are no hospitals with that number of stroke specialists in them. Most hospitals have one or two, if you're lucky, maybe 3 stroke specialists in some of the bigger centers dedicated to it. So we use what we call a virtual hub, not a conventional hub. Our telestroke neurologists, and those are the pictures of the 11 of us, are distributed throughout the state. Our day jobs are not even all based in Sydney. And I put a red box on myself, not to highlight myself, but to show I'm the only one actually at what we call the host site, the Prince of Wales, which is the administrative site. You've got to have a support center, but the hub itself, when you call that number, you might be reaching somebody in John Hunter or Gosford or one of the other hospitals in Sydney. So this is, it's a complicated figure, and I'll try to get through it, but it's basically a diagram showing what we call our model of care. And what happens is if a patient shows up at one of our hospitals FAST positive, you all know what FAST is, so they show up at one of the regional hospitals with symptoms possibly relating to stroke, they go through a screening program. We call it the ASAP screening program. And if that suggests that they have a stroke that would be amenable to reperfusion therapy, they call the 1-300 number, and immediately they're talking to us. There's nobody in between. So I was on call on Monday night. You're talking to me immediately, the doctor there, the emergency doctor or the doctor at the local hospital. We discuss the patient, and if it's as advertised, we go to the CT scanner and we acquire all those images I showed you before, the multimodal CT. And then we look at the patient and the family, the caregiver, through an audiovisual link. And the way we do that is, it's a little small there, but we put a camera and an audio set on what we call a workstation on wheels, which are everywhere in the hospitals. And that allows me to actually see the patient, talk to the family. So I gave lysis on Tuesday morning, and I was able to get a good history from the patient's wife about what happened, and assess him and then give him the thrombolysis. And that's what we're trying to do. If he'd had a large vessel occlusion, he didn't, he had a medium one, then I would have actually arranged for him to get on a transport, usually air transport, and bring him to the nearest comprehensive stroke center for clot retrieval. Clot retrieval, unfortunately, is very specialized, and it requires a big team with a lot of equipment, so that's still restricted really to centers in Sydney and Newcastle, and that requires transport. I'm just going to skip over that in the interest of time. This actually is kind of interesting. A lot of you have probably heard stories about patients that they thought they had a stroke and then they went to hospital and it turned out they didn't. This is our ASAP screening dashboard, and so we can see this all the time. And we actually see people getting screened who are FAST positive and a live real-time view. So, and it's really helpful because when they call us, I can actually look in and say, oh, this is your patient here, 67-year-old woman presented at 4 hours ago with this symptom here, and we can go through it and they say, yeah. And it's actually really fascinating to watch and see there's a lot of patients who have stroke-like symptoms that don't have a stroke. And that's just been interesting for us to watch. So this is a map of our activity right here across the state. So those are the 23 centers, and each of those colors, they may not mean anything to you, but the state of New South Wales is broken down into local health districts, and that's what those colors are. But the size of the circle corresponds to the number of patients that we've seen at each of those centers. So you can see the big blue circles there, Port and Coffs. And many of you have been to Port and Coffs. They're basically small cities. They're good-sized places, so there's a lot of patients there. They also had a head start because they were the only two that started before the COVID pandemic. So they got a little bit of a jump. Everyone else got slowed down by the COVID pandemic. But if you look at places like Lismore and Tweed and Shoalhaven, those were centers that actually didn't even treat stroke patients before we started the service. They were on bypass. So patients, if you had a stroke in Shoalhaven, you went to Wollongong. So that's another hour on the highway. And now they're one of our busiest, most effective stroke centers in the state. And you can see we've treated since March 2020. We've nearly 20,000 patients have shown up with possible stroke symptoms at those hospitals. We've done nearly 5,000 consultations, and we've treated over 1,000 patients, either with alteplase, with clotbuster therapy, or with clot retrieval, or both. And this is a breakdown of what that treatment looks like. And sorry, this is a little bit medical, but basically if you look at those 1,000 patients, 1 in 4 of them are getting clotbuster therapy, either alone or in combination. So a combination means we give the clotbuster therapy and then transport them out. And then another, just under 10% are being moved out for clot retrieval alone. That means we couldn't give them clot-busting therapy, usually because they're on a blood thinner, that's a contraindication. That compares very favorably with the national average. Now, it's a little bit unfair, because it's a lot unfair, actually, because we've enriched the denominator, right? We have selected the patients who who are eligible for therapy, whereas the national audit is just taking all comers who show up at a hospital with stroke symptoms. So we've enriched that number a bit, but we do know that we are one of the leaders with respect to delivery of thrombolysis nationally. And I suspect we don't have these same kinds of numbers for Sydney and the Newcastle area, but I suspect you've probably got as good or better chance of getting treated in these centers than you do in many of our metro centers. Most of you know the mantra, time is brain. You know, if you have stroke symptoms, that's the T, time to call an ambulance, 000, get into hospital. And we have the same approach once the patient gets to hospital. We want to be very, very quickly. You're losing about 2 million neurons a minute, brain cells a minute, when you have a stroke. So the faster we can open that artery, the better. And the international standard is to try to get treatment started within 1 hour of you hitting the door. So get to the emergency department, get through triage, get to the CT scanner, get examined, get the diagnosis, and get the treatment in. And when we started this program in 2020, we were over an hour, but we've consistently come down every year, and we're currently sitting at 53 minutes, which again, compares very favorably with the rest of the country. That's about 60% of our patients are being treated within an hour, which is about double the national average right now. That's been recognized nationally and internationally. This is the World Stroke Organization's ANGELS program, and they have an award system based on how well you treat your patients, how fast you treat them, and how often you treat them. And they have gold and platinum level awards, and you can see that many of our sites, in fact more than half of our sites, have been consistently awarded. These are awards that are handed out on a biannual basis. And many of our sites are consistently winning those awards, which is something we haven't even been able to do in my own hospital in Sydney. not all hospitals, as Kylie will point out. Some Sydney hospitals do well, but not mine. And I'll just show you what that looks like. And I think many of you will actually appreciate this, right? So this is one of my patients that I saw by tele-Stroke at one of our sites. And she was at dinner with her husband, and she fell down just as she was about to sit at the table, and she couldn't talk. And she was brought to hospital, and I talked to the doctor, and I said, get her to the scanner. And I saw these images as she was still in the scanner. So I could tell she had a blocked artery. I don't know if I've got an arrow on this one, but she's got a blocked left middle cerebral artery. And that green area there is an area where she's not getting blood flow. And that controls her speech and her right side of her body. And that's why she had those symptoms. So I asked him to give her a clot buster right there in the department. And we managed to do that, again, within an hour. And then it was a big clot, and I said, okay, let's get her to Sydney. We need to get her into an ambulance and get her to Sydney. She was not so far away that she needed air retrieval. I called the neurologist at that hospital, and I said, be ready for her? And he said, I will. And when she got there, she could talk, and she was moving. And he said, well, I don't know if you really need an angiogram, but if you want, I'll do one and have a look. And she said, okay. So he did, and he showed that we had opened the artery, and that's what you're looking at there. So he didn't have to do a procedure. That's a happy day for everyone. She had a scan the next day, which didn't even show a stroke. If she had an MRI, we probably would have seen something, but she was so good, they let her go. And we lost track of her until she showed up in her local paper as a good news story. And there she is. I don't doubt she'd actually remember me. I think her husband and her daughter would, who were there. But that's why we do this. That's why we have tele-Stroke. Without tele-Stroke, that lady wouldn't have been treated with a clot buster. The best she could have hoped for was probably a slower diagnosis and a trip to the city, at which point a lot of damage would have occurred, even if she did have a clot retrieval. And that's really emblematic of what we're doing, trying to get people home. She's a stroke survivor, but she's a stroke survivor with no disability, which is what we want. We have been recognized at the completion of our program with a number of awards, including the Premier's Awards. I think Danielle's in there somewhere. This was started as an implementation program. It was funded through a combination grant through federal and state money. The economic analysis has not been published yet, but I can tell you I've seen the results, and it's favorable. It does cost money to deliver this program, but it's by health economic standards, it's well worth the money, and that's what the economic analysis publication will show. And now we're in what we call the business as usual phase. Now, in true Australian fashion, many of our colleagues have not celebrated the success. Some of our colleagues, right? And the response has been, well, you finished that program, let's blow it up and start again. Which, you know, there's a syndrome for that. But our approach is no to that answer. And business as usual doesn't mean disengagement. We remain really engaged, and these are pictures actually just from the last month. So we still go out to our primary sites. Here you can see James and the Prince of Wales team at Moruya. Then I'm doing a sim there in Tamworth, and then you can see I think the whole hospital came out in Armadale to hear me talk, pretty similar to the talk I'm giving you right now. Actually, the one with the 3 people standing there at the foot of the bed, that is in Bega, and they were about to do a simulation, that's what we're doing there. We're practicing to get faster, right? You do simulations just like you do for fire drills, et cetera, like any other emergency situation. And that patient came in, and I'm actually treating the patient for real here in Sydney. And that's my patient right there who came in during the simulation. Now, what else could we do? Sometimes in medicine, people deliver programs and sort of rest on their laurels. But in fact, there are other things that we could do for people in regional areas with respect to stroke. You've probably heard a few years ago, there was a lot of controversy about using virtual health services, trying to replace doctors, take doctors out of communities. And what all the reports that were done based on that work, and one of the big controversies actually was, you'll recall, a patient who had a stroke who was not managed well, probably had a preventable stroke that had one and was it was related to a news personality. You may have seen that. But one of the recommendations was that virtual healthcare should actually supplement, right? It shouldn't replace what's going on. We're not trying to take doctors and nurses out of these regional areas. You still need somebody there. What do we as healthcare professionals do? Like, it's something we've sort of lost, right? That touch, that being physically present with people, that is important and remains important. But there are things when it comes to super specialist care, you can't put a super specialist in every little place. Even in Sydney, that's a challenge. And one of the places that we've identified, we sort of feel like we've got that front end covered. But as you know, the stroke patient journey doesn't end at that first hour after you hit the emergency department. There's that acute hospital phase where people are trying to figure out, as we heard here today, what did cause my stroke, right? How frustrating is that you went all through all that and nobody could tell you what caused the stroke? Sometimes that happens anyway, but sometimes it's because you didn't have a stroke specialist weigh in, do the right investigations, and determine why you had a stroke, and more importantly, give you the right medication so you don't have another stroke. And that's something that we think we can help with virtually as well. And we get a hint of that because we do follow our patients after the first hour. This is the multidisciplinary team meeting. We have this every Friday between 1 and 2:30. We review every case that's come through as a team across the state. We use the Teams platform, and we look at all the images from the patients, and we hear from the local team how the patient's doing, and also we relate the case as we treated it that week. The 11 of us, we go through all the cases. That's how we ensure quality, but it also gives us a little hint that maybe in some cases people could use a little help because they don't have stroke units, they don't have multidisciplinary teams. Some of you may not know this, but the entire southern part of the state, the southern local health districts, so Bega, Maruya, et cetera, those hospitals don't have a stroke unit. So those patients have to go to Canberra for stroke unit care. And what we would like to do is, because they don't have the services there, is provide a virtual stroke unit. And this is what a multidisciplinary team looks like, right? That's a meeting right there. It's not doctor-led. Stroke units really work because doctors stay out of the way. It's physiotherapy-led, occupational therapy, nurses, dietitians, speech-language pathologists, the people that are really helping you get moving and get to where you need to be. And that's what a multidisciplinary checklist looks like right there. And that's what we'd like to do next. I'm going to quickly switch gears and talk to you about something sort of different, but it's going to set up Professor Anderson's talk, I hope, a little bit. Anybody heard of AI? Probably heard a lot about artificial intelligence and a lot of talk about artificial intelligence in medicine in particular. And you may have an idea in your mind what that looks like. A lot of people, it looks like this, right? This is ChatGPT, and it's type into ChatGPT. I actually did that, right? I have a patient in the emergency department with a stroke. What should I do? It'll tell you. It'll give you an answer. That's not really what AI in medicine is about. Although, having gone through all of the safety frameworks and everything, all of our IT people seem to think that's what it is. Everything's sort of geared at that. What about a system that's hallucinating? In fact, we're not at that level. We're not at the point where we're replacing the doctor with ChatGPT. But there are things that AI is really ready to help us with. The truth is AI is actually much more mundane, and if you really want to use it, this is actually what it looks like. It's coding. It's not actually at we're not Star Trek yet. We're not talking to the computer and it's telling us what to do. You still need to sit down at the console, and this is a program that I wrote some of this code, obviously with a lot of help from people who actually know what they're doing. But what it does is actually measure stroke volumes. And I've come back to that Rodney Dangerfield of stroke, that intracerebral hemorrhage stroke, hemorrhagic stroke. And this is an area that Professor Anderson and I have been involved in for much of our careers, have been interested in. And there's been a bit of a divide between our research careers, what we do, in our clinical research, and what we do at the bedside, clinically. And one of them is volume measurement. We know with this type of stroke, size does matter. So small hemorrhages do well, big hemorrhages don't do well. It's a pretty easy, intuitive concept to get your head around. But measuring volumes is really time consuming. We would typically do those manually, and I'm showing you some software that we use here to manually basically paint with a mouse that hemorrhage in 3 dimensions and get that volume. It would take me to do that case there, generally about 10-15 minutes to do one case. We don't have the tools at the bedside or the time, and neither do radiologists, right? So radiologists will just use a qualitative description. So those are both described as large hematomas, and I think you could probably appreciate that the one on the bottom is actually much larger than the one on the top, but from a radiologist perspective, that's good enough. But we do know that the one on the top is survivable and the one on the bottom is not. And making those kinds of decisions about who's going to survive, who we should treat aggressively, who we should use drugs with potential side effects on, is actually based on the volume. And we can make better decisions if we get the volumes. And I won't go through all the details of the AI, but basically, one of the things that we've done through my research grants is develop an AI system that does that for us in real time. So it measures those volumes. So for the first time, I got 2 minutes, only got about 10 slides left. For the first time, we've got tools that will measure those volumes for us and actually put those into the clinical systems we use. Take it, and all I really wanted to show you here was we're taking research out of little silos and we're making it clinically useful. And that's something that was not possible 5 years ago, pre-AI and pre what we call cloud computing. That's what cloud computing is, and I won't bore you with the details, partly because I don't have time anymore. That's all you really wanted to know there. Why that matters, and this is the setup slide for Professor Anderson, is he's going to talk to you about hemorrhagic stroke, and he's going to talk to you about how we should be treating. We should be aiming to treat blood pressure, and if the patient's on an anticoagulant, we should be reversing that anticoagulant as fast as possible. And we're starting to do that. We have a registry where we're doing that. We're doing that now in tele-Stroke. But the outcome that we care about is volume growth of the hemorrhage, right? The stroke volume. Well, you can't do that if you don't measure it. And that's where we think our tools will be useful. We're applying it to other different types of stroke, including stroke in the eyes too. I've got an optometrist here who'd be interested in that. I won't get into all of those things there in a minute. Ultimately, what we would really like to do, and I'm going to race through all this here, just get to my top line, is we would like to use AI to help us make better decisions about who we treat, not just in hemorrhagic stroke, but also in ischemic stroke. And one of the toughest decisions I have to make is, and you don't need to see all this data here, the main thing really is that helicopter there, right? Imagine you're in Dublin and your mom has a stroke and she's got a clot that maybe we could retrieve and she might do okay. But to do that, it means she's got to get on a helicopter, she's got to go to RPA. You don't get to go on the helicopter. You and your children have to trail along in a car. And sometimes what happens is they get to RPA and the damage is done and the procedure either isn't done or wasn't successful, and they go back on a helicopter and they go back to Dublin. And then you get to RPA, and now you got to go back. And what would you rather do? You'd rather spend that time with your mom. Your mom didn't need to go through all that, right? And if we could predict better, and this is the promise of artificial intelligence, if we could predict better, no, actually your mom is better off staying here in Dublin with you. It doesn't make sense to go through all this. It'd be better for her, it'd be better for the family, and it'd be better for health. And I'll stop there. Oh, taking questions now?
Yes.
Oh, okay.
That's why Michelle finished early. Anyone got any questions to start? Yep. Where's the microphones? Over in the corner.
Ambulance-based CTs a reality yet?
They are.
Is there many?
Sorry?
Are there many?
They're not. So in Australia, there's one. It's in Melbourne. In Canada, there's one. It was in my city where I worked in Alberta. They are an excellent idea. They're an excellent concept. At this stage, they're still really at the proof of concept, and actually the concept has been proven, but they're expensive. Really resource intensive. And, you know, the impact that they have in a lot of places is fairly marginal because, you know, if you're close to a hospital anyway with a better CT scanner and all the people, probably better to just keep going. There is a niche role for them. Pre-hospital imaging will no doubt one day become the norm, but it won't be that way until we have imaging in all the ambulances, not just one big specialized ambulance, so that when the ambulance shows up at your house and the paramedics say, you've had a stroke, it looks like you're having a stroke, they can call us. We say, let's do the imaging, but the imaging won't be a big CT scanner. It'll, you know, I'm talking Star Trek medicine here, right? But it'll be something that fits in an ambulance, that isn't too big, is easy to use, and we look at the images and we say, okay, you can give the treatment for stroke right there at the patient's house and then bring them here. But I think we're still a ways off on that yet. Yeah.
I'm just wondering if you wouldn't mind addressing the issue of education of staff at your smaller rural hospitals and what's involved in that for the telestroke team, please.
Yeah, I mean, it's a constant effort, right? It's like fast campaigns. You know, they're only as good as they're active. People know that when fast campaigns are on, people think about stroke, and if you don't do them for a couple of months, people forget it. And really, in-hospital education is no different. That's why we go to all of our sites every year and we do those simulations. We have education and we review with them. We also have monthly meetings where we review all the cases at a site level. We also do simulations even when we're not there. So they'll do simulations on their own, but with us in Sydney, for instance, or Gosford, or wherever the consultant is, but we'll go through mock cases where one of the staff will be the patient. It's just constant. You cannot stop. It's CME, it's continuous medical education, recertification. Every healthcare profession does it. That's what medicine is. It's lifelong learning, and if you stop, you suffer.
Thank you.
Will AI in the future mainly be for diagnosis, or will it transfer or progress into physio, speech, and OT?
Sorry, will AI only be used for diagnosis? Is that, yeah. I focused on that because that's what I'm interested in. I do see AI applications throughout medicine, absolutely. There's some pretty obvious ones in rehab, right? With VR coming, and full disclosure, not a rehab specialist, not a therapist, but just taking a peek in as a spectator, I can see real interesting applications there where, you're putting on these virtual reality headsets and the AI is adjusting to you in real time and adjusting your rehab. But more importantly, what's rehab about? A lot of it's about practice and what you put in, and AI can make that more interesting, right? It can keep you engaged, hopefully, and that leads to better outcomes.
We've got a question online.
Okay.
So do the telestroke capable hospitals have to have CT perfusion scans on site?
They do. In 2024, I don't think you could actually buy a CT scanner that isn't CT perfusion capable. So in New South Wales, I think there are too many scanners left that can't do perfusion or angiography. But yes, it's one of the hallmarks of our program is we have a very uniform approach to everything. We kind of treat it like those oil change shops, right? Come in, everything's done the same way every time. There's no custom jobs, there's no choose your own adventure, and that's how you get fast.
Any other questions?
I'll do another one online if there are no other questions in the room. Yep. So do the patients stay at the regional hospital after the TPA if there is no LVO, or do they still get transferred to the Comprehensive Stroke Centre?
So in most cases, they stay. That's our ideal because we want them to stay in their home communities. Again, that's building capacity locally. Stay close to your family, your support systems, et cetera, your caregivers. The only places where they would move where they don't have an LVO is if you don't have a stroke unit. So some of our really small places, so if you have a stroke in Deniliquin, for instance, if you've ever been to Deniliquin, it's 10,000 people. They all know each other. It's really small, and they don't have a stroke unit, and they need that level of multidisciplinary care, right? They need the therapists, et cetera. So those patients have to go to Wagga Wagga, which is their closest stroke unit. Same with Griffith, they'll go down. And then in the south, that LHD we actually have covered pretty well with Wagga. It's at least you're still in the state. The one we're really concerned about are the patients down in southern New South Wales that end up going to, effectively out of state, going to ACT.
There's one more online. So is TNK considered better than alteplase for telestroke patients who may need urgent transfer in order to save time?
Yeah, so TNK, for those of you who don't know it, is tenecteplase, whereas TPA, what I was talking about here, is called alteplase. And as you probably guessed by the names, chemically, they're very, very similar structures. There's just a few what we call hydroxyl groups that are changed, and one tenecteplase is actually a form of alteplase. It's based on alteplase, and it was engineered to be theoretically better than alteplase. Developed first for cardiology for treating heart attack, right? Well, myocardial infarction, we call that heart attack colloquially, and it was never actually shown to be superior for that, but it is easier to use. So you don't have to give alteplase is an infusion given over an hour. You have to give part of it as a bolus and then hook up a pump. And tenecteplase is actually much easier to use because it's just one injection. It's a simpler injection, a simpler thing to mix up, and then one injection and you're done. And I've been using tenecteplase in research studies since the first time I used it was in Alberta in 2006. It's at least as good as alteplase, it's not worse. Where you get into trouble in healthcare systems is when you start using two different drugs in the same emergency department for the same indication, because the doses are different and how you do it, and that's how mix-ups occur. And right now in Australia, we don't have enough tenecteplase to treat the people that it's indicated for in Australia, which is MIs, heart attacks. So it's reserved for them in New South Wales, and we use alteplase. Tenecteplase, will get an approval. It's got one around the world. It will get an approval, and when that happens and there's drug supply, we will make the switch. But again, like our approach to imaging, it won't be halfway. I was thinking about, I had a term that wasn't very, it was colorful, but I didn't want to use it. we will go, it's all in or all out. And right now, we're not ready, but when we are, which hopefully is next year, we'll make the switch.
I think that's time. Thank you very much.
You're welcome.
Ken.